Polypharmacy versus Parsimony. In psychiatric practice, we face a constant tension between two competing requirements: the duty to provide comprehensive symptom relief through multiple interventions and the need to practice evidence-based, rational pharmacotherapy with the minimum necessary complexity. This tension is captured in the dichotomy between polypharmacy and parsimony. Let me be straight. The appeal of polypharmacy is understandable. A patient presents with multiple symptoms: depression, anxiety, insomnia, irritability, poor concentration. The impulse is to address each symptom with a targeted agent: an antidepressant for depression, a benzodiazepine for anxiety, a hypnotic for insomnia, a mood stabilizer for irritability, a stimulant for concentration. Before you know it, the patient is taking 5 medications, none of which has been studied in combination with the others, all of which interact in ways we can only guess, and the clinical picture has become so muddy that determining what's helping and what's harming becomes impossible. This is not evidence-based medicine. This is pharmacological improvisation. The 4 cardinal rules of rational prescribing. Allow me to propose, or rather to insist upon, 4 fundamental rules that should govern psychiatric prescribing. These are not suggestions. These are the foundational principles of rational pharmacotherapy. Rule number 1: the medication must match the DSM-5 diagnosis. Yet it is violated with stunning regularity. The medication you prescribe must have either an FDA-approved for that specific diagnosis or an off-label indication supported by randomized double-blind placebo-controlled trials, meaning studies published in peer-reviewed journal demonstrating efficacy for that specific condition, even if the FDA hasn't formally approved that indication. On very rare occasions, perhaps 5% of the clinical situations, you might need from this rule when dealing with treatment refractory cases or unusual presentations. But in 95% of the cases, you don't have to, because these 2 categories, FDA-approved indications and off-label indications, give you plenty of options. Why is this rule so critical? Because without it, we are practicing a speculative pharmacology. We are prescribing medications based on theoretical mechanisms, clinical hunches, or worse, pharmaceutical marketing, rather than on demonstrated efficacy. If a patient has a major depressive disorder, you prescribe an antidepressant with proven efficacy in depression. If they have bipolar disorder, you prescribe a mood stabilizer or an atypical antipsychotic with demonstrated efficacy in bipolar disorder. If they have schizophrenia, you prescribe an antipsychotic with evidence from studies that it treats psychotic symptoms. This may sound basic to you, but I assure you violations are common. Antipsychotics prescribed for anger in personality disorders without evidence, mood stabilizers prescribed for mood swings that are actually reactive emotional states, not bipolar spectrum pathology, stimulants prescribed for low energy in depression when the evidence supports treating depression first. Match the medication to the diagnosis. It's not optional. Rule number 2: introduce it slow or very slow. The principle here is straightforward. Start low and go very slow, or in more severe situations, start low and go slow. Why? Because tolerability determines adherence, and adherence determines efficacy. The most effective medication in the world is worthless if the patients stop taking it after 3 days because of intolerable side effects. Most psychiatric medications have side effects that are front-loaded. They emerge immediately or within first few days, while therapeutic benefits are delayed, often requiring 2 to 4 weeks to manifest. This creates a predictable problem. Patient experiences all the discomfort with none of the benefits early in treatment, which is precisely when discontinuation risk is highest. Slow titration allows the body to adapt. Neuroreceptor regulation, metabolic enzyme induction, and physiological accommodation all take time. Rushing the process increases side effect burden without accelerating therapeutic response. There are situations when faster titration is necessary: acute psychosis, severe mania, imminent safety risks. But even then, we titrate as slowly as we can. Rule number 3. Raise the dose until the benefits are apparent, side effects preclude further increase, or maximum dose is reached. This rule addresses the common error of underdosing. That means prescribing subtherapeutic doses and then concluding the medication doesn't work. Once you've started medication, your obligation is to give a full adequate trial. That means titration to a dose where therapeutic benefits become apparent, or reaching a dose where side effects prevent further increases, the maximum tolerated dose, or reaching the maximum FDA recommended dose according to the package insert. Then you wait. After 6 to 8 weeks at maximum dose or maximum tolerated dose, you assess the outcome. The patient may have improved very well. Symptoms are largely resolved. Functioning is restored. Just enough. Some improvement, but residual symptoms remain. Not enough. Minimal improvement, still significantly symptomatic, or not at all. No discernible benefit. This assessment determines what your next decision will be. Rule number 4. Decide whether to continue, add something, or replace. Based on 6 to 8 weeks assessment, you have 3 options. Continue the medication if the patient improved very well. Just continue the medication at that particular dose. Monitor for relapse, but don't change what's working. You can add if the patient improved just enough or not enough, but did show some response. Consider augmentation with a second agent targeting residual symptoms. And you can also replace if the patient did not improve at all, or if side effects are intolerable despite benefit. Discontinue and try a different medication. Critical principle: try as much as possible to avoid making 2 changes simultaneously. Don't add a new medication while simultaneously increasing the dose of an existing one. Don't discontinue one medication while starting another unless medically necessary. Important clarification: the principle does not apply to cross-tapering, which is a standard method of changing medications in psychiatry in most circumstances. Cross-tapering, where you gradually decrease the old medication while simultaneously and gradually introducing the new medication, is both necessary and appropriate. It prevents withdrawal syndromes from abrupt discontinuation, maintains symptom coverage during the transition, and is the established standard of care. What we are cautioning against is making additional unrelated changes during medication switch. For example, don't cross-taper from one antidepressant to another while also adding a new mood stabilizer and increasing the dose of an existing anxiolytic. That creates an uninterpretable mess. Cross-tapering itself is one coordinated change. Medication A is being replaced by medication B through a deliberate gradual transition. That's a single interpretable intervention. But beyond that necessary overlap, avoid simultaneous modifications. Why? Because if the outcome is adverse, worsening symptoms, new side effects, unexpected reactions, you won't know which change caused the problem. Was it the new medication, the withdrawal from the old one, the dose increase of the third agent, the interaction between multiple changes? You've created an uninterpretable clinical scenario. Make one change at a time, or in the case of medication switching, one cross-taper at a time. Observe, assess, then decide on the next change. Sequential modifications create interpretable data. Simultaneous medications create chaos. The appealing strategy of polypharmacy. Now let me address a prescribing philosophy that has gained troubling popularity. The use of multiple similar medications at low doses to quote-unquote fly under the radar, meaning to stay well below the maximum dose of each individual agent to theoretically avoid side effects while maintaining efficacy through additive effects. The logic sounds reasonable. Instead of prescribing one antidepressant at 200 milligrams, prescribe two different antidepressants at 100 milligrams each. Instead of one antipsychotic at high dose, prescribe two at a moderate dose. The theory is that you get the therapeutic benefit of combined action while avoiding the dose-dependent side effects of any single agent pushed to the maximum. This strategy has four fundamental problems. Problem number one, no evidence that multiple low doses avoid side effects. There is no empirical evidence that prescribing several similar medications in small dosages instead of one at an adequate dose avoids the patient experiencing side effects. This is an assumption, not a demonstrated fact. In reality, side effects from psychiatric medications arise from receptor activity, not just from the dose. If you are targeting the same receptor system with two medications, say two SSRIs, both blocking serotonin reuptake, you are still creating the same receptor occupancy and downstream effects. You haven't magically eliminated side effects, you've just distributed the receptor blockade across two drug names instead of one. Moreover, side effects from drug interactions may actually increase with polypharmacy. Two medications metabolized by the same hepatic enzyme system can compete for the metabolism, raising serum levels beyond what you intended. Two medications with anticholinergic properties can produce additive cognitive impairment even at individually quote-unquote low doses. The idea that polypharmacy is inherently better tolerated is pharmacologically naive. Problem number two, absence of evidence for combinations. Here is the uncomfortable truth. We have barely enough studies proving the efficacy of psychiatric medications when taken alone. The evidence base for monotherapy is itself incomplete and limited by short trial durations, publication bias, industry funding, and selective outcome reporting. But at least we have some randomized double-blind placebo-controlled data for single agents. For combinations, well, we have an extremely small number of studies looking at two psychiatric medications used simultaneously. Lithium plus an antidepressant, an antipsychotic plus an antidepressant, a benzodiazepine plus an SSRI for the first few weeks. These are the only combinations with meaningful evidence. For three medications used simultaneously, the evidence base is minuscule. A handful of studies, mostly in the treatment-resistant cases, usually industry-funded, often with methodological limitations. For 4, 5, 6 medications, there are essentially no controlled trials. We are in completely unknown territory. We are conducting uncontrolled experiments on our patients guided only by clinical intuition and theoretical extrapolation. Why is the evidence base for combinations so sparse? The reason is both practical and financial. The enormous number of possible combinations that would need to be tested makes comprehensive study usually impossible. Consider the mathematics. If you have just 20 commonly prescribed psychiatric medications and want to study all possible two-drug combinations, you are looking at 190 unique pairings. Add in those variations, say 3 different dosages of each medications, and you now have over 1,700 combinations requiring separate trials. Extend this to 3 drug combinations and the number explodes into tens of thousands of combinations. 4 drug combinations, hundreds of thousands of possible permutations. And remember, proper methodology requires placebo-controlled designs. So each combination study needs not just the active treatment arms, but placebo comparison as well, further multiplying the complexity and sample size requirement. The financial reality is stark. A well-designed, well-executed, randomized, double-blind, placebo-controlled trial for a single medication at 3 dosages already costs tens of millions of dollars. Multi-site recruitment, regulatory compliance, monitoring, data management, statistical analysis. These are enormous, expensive undertakings. To comprehensively study even a fraction of clinically relevant drug combinations would require billions of dollars and decades of research effort. No pharmaceutical company has the incentive to fund such studies. They profit from single-agent patents, not from proving that combining competitors' drugs works. And public research funding, while valuable, cannot possibly cover this vast territory. So we are left with a handful of studied combinations, usually those where pharmaceutical companies saw commercial advantage, and a vast landscape of unstudied polypharmacy that we practice daily without empirical foundation. Polypharmacy beyond 2 agents is by definition off-label prescribing without evidence. We are violating rule number 1. Now, rule number 3, the myth of simple addition. When we prescribe multiple medications, we typically assume that their effects are a simple addition. Medication A produces benefit X. Medication B produces benefit Y. Together, they will produce benefit X plus Y. This assumption is risky in complex biological systems. The human body is not a simple machine where inputs sum linearly. It is a complex adaptive system with feedback loops, homeostatic mechanisms, receptor regulation, enzyme induction and inhibition, and emergent properties that cannot be predicted from isolated components. Pharmacokinetic interactions alter drug metabolism. Pharmacodynamic interactions alter receptor activity. Downstream signaling cascade interact in a non-linear ways. The combination may produce effects that are synergistic, greater than the sum, antagonistic, less than the sum, or entirely novel effects neither drug produces alone. We discover these interactions through randomized double-blind placebo-controlled trials. That is the only method that reveals usable information about what drug combinations actually do work in human beings. Without such trials, we are guessing. Educated guessing, perhaps, but guessing nonetheless. Problem number 4, complexity, cost, and compliance. Finally, polypharmacy complicates the treatment regimen substantially, with predictable consequences. Increased cost. Multiple medications mean multiple copays, higher out-of-pocket expenses. greater financial burden. Patients on a tight budget face impossible choices about which medications to fill. Increased risk of non-compliance, both deliberate and accidental. Deliberate, when patients decide the regimen is far too burdensome and stop the medications selectively or entirely. Accidental, when patients forget which pill to take, when they confuse bottles, miss dosages. Studies consistently show that adherence declines as pill burden increases. Every additional medication added to the regimen decreases the likelihood that the patient will take everything as prescribed. Non-adherence produces unpredictable serum levels, erratic symptom control, and relapse risk. It also makes clinical assessment impossible. Is the patient not responding to the medication, or they are simply not taking it? The case for parsimony. All of this brings us to the inescapable conclusion. Parsimonious use of medication is logically the most preferred way to practice psychiatry, and the closest approach to the gold standard of evidence-based medicine. What does parsimony mean in practice? Use barely enough medications, the minimum number necessary to address the diagnosis and symptoms. Use barely enough of each medication, the minimum dose necessary to produce benefits, without automatically pushing for maximum dose if lower doses are effective. Follow the evidence. Prescribe medications with proven efficacy for the diagnosed condition at doses and durations supported by controlled trials. Make changes sequentially, one modification at a time, with the exception of appropriate cross-tapering, with adequate time to assess outcome before the next change. Question every addition. Before adding a medication, ask, is this targeting a new symptom? Is there evidence it works in combination with existing medications? Have I given current medications an adequate trial? Could simplification, that means discontinuing an ineffective agent, be better than addition? When is polypharmacy justified? I don't want to suggest that polypharmacy is never appropriate. There are legitimate scenarios. For example, treatment-resistant illness after multiple adequate monotherapy trials have failed. Rational augmentation strategies with evidence are appropriate. Lithium augmentation of antidepressant, antipsychotic augmentation of antidepressants in psychotic depression, clozapine augmentation in refractory schizophrenia, comorbid diagnosis. A patient with bipolar disorder and OCD may legitimately need both a mood stabilizer and an SSRI, as these are addressing distinct diagnoses with different medications that both have evidence of efficacy. Transitional polypharmacy. When switching medications through cross-tapering, there is a period of transitional overlap. This is temporary, appropriate, and standard practice, not chronic polypharmacy. Symptom-targeted augmentation. Persistent insomnia, despite adequate antidepressant treatment, might warrant adding a hypnotic. Residual anxiety, despite mood stabilization, might warrant short-term anxiolytic use. But even in these scenarios, the principles remain the same. Evidence-based selection, clear rationale, regular reassessment, and discontinuation when no longer needed. Conclusion. We live in an era of pharmaceutical abundance. We have dozens of psychiatric medications, many effective, some transformative. The temptation is to use them freely, to address every symptom with a pharmacological intervention, to assume that more is better. But the obligation of rational prescribing is restraint. It is the discipline to prescribe only what is necessary, only what is supported by evidence, only what can be monitored and assessed. We must be stingy with the medication. not out of cruelty or miserliness, but out of respect for the complexity of the system we are intervening in, the limitations of our knowledge and the well-being of our patients. Polypharmacy is sometimes necessary, but it should be never the default. It should never be the result of clinical inertia, where medications accumulate because no one bothers to stop them. It should never be the product of prescribing by symptom rather than by diagnosis. Parsimony is not minimalism for its own sake. It is evidence-based practice. It is rational prescribing. It is good medicine. Match the medication to the diagnosis. Start low, go slow. Titrate to efficacy or tolerability limits. Assess after adequate trial. Make one change at a time, respecting the necessity of cross-tapering when switching agents. Question every addition. Discontinue what isn't working. These are not constraints. They are framework within which effective psychiatric pharmacotherapy occurs. The most elegant treatment is often the simplest one. The best prescriber is not the one who uses the most medications, but the one who uses the fewest to achieve the best outcome. That is the art of psychiatric prescribing. That is the standard we should hold ourselves to.